So my name is Dr. Snellgrove. I am one of the internal medicine physicians here and part of the faculty. I primarily work in the outpatient office and primary care clinic, but I also do 1 week a month as a hospitalist working with the residents. You know, it's kind of our job as the primary care physician to of course, diagnose and start the treatment for a patient with diabetes. I'm going to go ahead and make the assumption that we know how to do a good history and physical and properly diagnose type 2 diabetes. And once we have that established in a new patient, then we can talk about how we manage the or go from there. So first and foremost, when you diagnose diabetes in a patient, the first thing you want to discuss with them in terms of management is lifestyle changes, that primarily being diet and exercise. In terms of diet, we talk about weight loss. Oftentimes in my office, I set a goal for the patient to lose around 5 to 10% of their body weight as a good start. And when I discuss dietary modifications, one of the things I have to be aware of is I can't assume that the patient knows that sodas are bad for them necessarily. I often have to have a discussion. What exactly are you drinking? What exactly are you eating? And then we can talk about low carbohydrate, low fat, low cholesterol, being very mindful of what you're eating and drinking. Additionally, in terms of exercise, approximately 36% of patients who are diabetic are physically inactive. It's important to exercise. When I discuss this with the patients, I usually say try to get at least 30 minutes of exercise at least 3 times a week. Ideally, it should be 30 minutes 5 times a week. And I say any sort of exertion that gets exercise that gets you sweating. Oftentimes they describe it as any sort of exercise where you can talk but you can't sing in terms of how much you're exerting yourself. Then we talk about medications. If we've talked about diet, we've talked about exercise. Oftentimes, if a patient is very reluctant to start anything, depending on what the glycohemoglobin A1C was or how elevated their glucose has been, we may give them a few months trying that alone and then checking it again. But first-line treatment for type 2 diabetes without any contraindications to taking the medication is metformin. It's a good drug. It's the first line that we use. And oftentimes with metformin, you can get a reduction to 1 to 2% in the A1C by starting that alone. I often start the dose at 500 milligrams once to twice daily, and then we can increase that, seeing on how they respond, up to 1,000 milligrams twice a day. The most common side effects of metformin that I've seen in my practice is upset stomach, GI issues, nausea, things of that nature. There's a very low risk in terms of hypoglycemia with this medication. Weight gain can be an issue with it sometimes for patients. In terms of dosing, we used to dose it based off of creatinine. Now we look at the creatinine clearance. If a patient has a creatinine clearance less than 30, it's contraindicated. If the patient's on the medication already, with the creatinine clearance less than 45, no greater than 1,000 milligrams once a day. More times than not, you start there and you see how they respond. And generally speaking, the goal is really to have an A1C under 7%. Now, that depends on the patient, their comorbidities, their age. Oftentimes we shoot for a target of 7.5 or even 8%. And it depends on where they started. Depends on where they start to where they land after treating them. But if they do need another medication, there are several other ones out there that we can try. All of them have their advantages and disadvantages, and I'll briefly talk about a few of them right now.